I'd like to introduce myself. My name is John Finicos. I'm a pharmacist here at the Brigham and Women's Hospital. I've been here for 27 years now. I was actually born in the hospital. So there's a special meaning for me here, and I truly expect to be here for the rest of my career. And as an aside, like most things when you work here, I've got just about every organ system covered, so if something goes wrong, I have a doctor that I can consult with for advice and information. I'm going to run in with some comments to begin the program because I expect there'll be people that'll be coming in and out as I start because of various things like, I know it was raining this morning, traffic is always an issue. Finding where the coffee is and where to sign in is always an issue. So if you'll indulge me for a few minutes, if I was sitting in your seat, and I have a million times, the first question is who are all these people hanging on the walls, right? And I will tell you, to me, this is a very hallowed, holy spot in the hospital because it's a reflection of centuries of learning and education. And I can tell you that we are in the Bornstein Amphitheater, okay? And of course, this is a question I would pose to my children, right? Who's married in Grant's tomb, right? What city is responsible for Boston baked beans, right? So who is the Bornstein Theater named after? Exactly. Now, and this is the second question I would ask my children is, can you name everybody in the room? Yeah. So, yes, it was Mr. and Mrs. Bornstein that donated the room and the renovations for it in 1993. And he was a chemist in the Boston area and actually did a lot with narcotic drugs. That was his specialty. See, Dr. Goldhaber has arrived, so we have to wave. And in his benevolence, he put the funds to renovate the room and set up many of the portraits. I'll also tell you that his child was stricken with cancer and is actually treated here in the hospital, and that's why it's a special place. I can tell you that on the wall here we have a Nobel Prize winner, Pulitzer Prize winner, somebody that came from Transylvania, Hungary, from the Soviet Union, a graduate of Yakima High School in Washington State. I mean, isn't that as far as you can get, right? Of course, the Harvard Medical School dean, nurses, and a farmer. And if you'll give me a minute, of course, the Nobel Prize is probably the big thing. And in the back here, if you happen to go through our lobby, you'll see the Nobel Prize in the Peter Bent lobby was won by Dr. Joseph Murray. And the three physicians in the back also had incredibly important roles in the first renal transplant that was done in the world. It was done here at Brigham and Women's Hospital. And more importantly, from that one kidney transplant emanated all the other transplants that are done in the world. The heart, the lung, things like the pancreas, and even the bone marrow. The individuals that were involved actually migrated to Washington State, and Fred Hutchinson Medical Center in Seattle did the world's first bone marrow transplant, and from physicians that actually started here at Brigham and Women's Hospital. And if you read the newspaper just recently, the donor, the brother that received, there were twin brothers, the brother Ronald Herrick that received the renal transplant died after about 10 years. The donor brother just passed away a few weeks ago. He lived in Maine and was on the staff of University of Maine College. When I hear that story, the person that I'm always most interested in is actually not the folks that did that actually worked on the stricken individual, but Dr. Hartwell Harrison was actually responsible for taking the donor kidney. So if someone was under stress, wouldn't it be the person that was working on an individual that was perfectly healthy and probably could have had something gone wrong? We have a Pulitzer Prize winner, Harvey Cushing, who did enormous amounts of work in the turn of the century in neurologic diseases. He has a syndrome named after him. It's related to pituitary illness. He actually won his Pulitzer Prize for his illustrations because we didn't have 7 years to find out whether they understand the information surrounding the drug, that they understand how to take it, and more importantly, that they understand what to do if something goes wrong or it doesn't happen or an unexpected or untoward event occurs, what they do in response to that. So let me finish. We know here in the hospital that we need to pay attention to how well patients take their drugs, and that opens a whole Pandora's box about what we need to do with patients once they leave the hospital and take medications home with them. And that is going to be the next area of our clinical focus. We are experimenting now with direct patient education and interactions. We're taking time out of the day to talk to patients, to find out what the barriers are to adherence and what can be removed, and certainly look at the tools that can improve patient medication as we move forward. So with that, I have on my clock 9:21, and I was supposed to finish at 9:20. So we have, how about that, huh? I'm 1 minute over. I'm 1 minute over. So I've provided you with a lot of information. We have about 5 or 6 minutes right now, and I'll open it up for any questions. Portraits, I think I can answer most of your questions. Pictures, etc. Fire away.
I understand that the heparin was contaminated in 2008, but when did the actual warning go out?
So the question is when did the warning go out for heparin? I want to say it was January of 2009. Okay, so I believe the first alert. So how this played out is the MedWatch program. The reports came in 2008. In late 2008, in December, the FDA recognized there was a cluster of deaths in a Missouri children's hospital. They went to investigate. They traced the drug, heparin, back to a facility in New Jersey. And they made the facility withdraw their heparin from the market in January of 2009. And within 3 or 4 weeks, they realized that the problem was much, much bigger than that. And that not only was it that one batch of heparin, it turns out there were problems with all kinds of batches of heparin, and not only from that one company, but from multiple companies. And not only did they pull all of the heparin from that company, they pulled all devices. So we have heparin-coated catheters, collection tubes, etc. So it was about in March that they realized there was a major problem. It took about 6 months later before them to identify the contaminant. And then by the fall, the FDA had put in measures to assess the raw materials that were coming into the United States for the presence of that contaminant. The contaminant was something called over-sulfated chondroitin. So basically, heparin comes from pig intestine. If you take other parts of the animal and throw it into your batch of preparation, you get a bigger batch and you can sell it for more. I think we have eliminated many of the problems, but it magnifies or suggests to you that we could do better with newer agents, I think, that Dr. Goldhaber is going to talk about than the agents like heparin or even warfarin. Does that answer your question?
Yes, it does.
Heparin is nothing more than a sugar molecule. So if you take simple table sugar, okay, heparin is nothing more than small sugar molecules that are linked together in a big, long chain. And for whatever reason, there was a young man at Johns Hopkins in the 1800s that was looking for materials that would cause the blood to clot. And he took this material and found it prevented the blood from clotting in the 1800s, and we are still using that agent today. So it is nothing more than a sugar molecule. Warfarin is different. We'll talk, and I know Dave's going to talk a little bit about warfarin later on, because that we can make in is a relatively small molecule. We still get the chemical from China. We still have sources of pig from Europe. But the standards across the world changed essentially overnight in terms of providing safety. Now, could the event happen again with some other drug or some other agent? Sure. because people are very, very ingenious. Question in the back.
That the results are good, but they're not nearly as impressive as they are for atrial fibrillation. The atrial fibrillation paper was called RELY, the one we just discussed. The one on DVT and pulmonary embolism is called RE-COVERT. And it was published December 10, 2009 in the New England Journal. The RELY paper was published in the summer of 2009. Same journal. Okay, so here's the design of the RE-COVERT trial. It had to be DVT or pulmonary embolism. All patients received injectable anticoagulation, usually low molecular weight heparin with enoxaparin for the first 10 days or so. The feeling being that dabigatran isn't a strong enough anticoagulant when a new pulmonary embolism or DVT has first been diagnosed. And patients were randomized either to dabigatran or to warfarin. Those patients who were randomized to warfarin began receiving it right away. And those patients who were randomized to dabigatran didn't get it right away. They got a placebo for warfarin the first week. It's kind of interesting the way you do these studies, and some of you have participated in ours, have come to our office and have participated in these studies. How do you do a double-blind study so the patient, the doctor, the nurse don't really know whether you're taking the real dabigatran or the real warfarin? So for those of you who haven't been in one of our trials, we have these little point-of-care fingerstick machines. You're going to hear more about these later. But we use a souped-up version that the machine, we put in a serial number. The machine can then identify whether the patient in the trial has been randomized to real dabigatran or to real warfarin. All the patients in the trial are taking both sets of pills, but one of them is a placebo and one of them is the real thing. Actually, dabigatran isn't a pill, it's a capsule. And so everyone in the trial is taking a capsule, one capsule twice a day, or which is either real or placebo, and they're also taking warfarin in the evening, which is either real or placebo. The machine, but not the nurse and not the doctor, not the pharmacist, not the patient. Only the machine knows what the patient's assigned to. And if the assignment is warfarin, the machine gives the real INR. On the point-of-care machine, we take a drop of blood from the finger. 2 minutes later, you get a real INR. We adjust the warfarin dose. If the patient's taking dabigatran, which has no dose adjustment, the machine generates a fake INR. And it tries to generate it similar to what would be with the real world with warfarin. So about 65% of the time, it gives an INR within the therapeutic range of 2 to 3, so that there's no adjustment of the placebo warfarin tablets. But the other time, the machine will come out with a very low INR of like 1.3, so then we're giving more placebo pills. And then sometimes it comes out with a value like 4.0, so we're decreasing the milligrams of placebo for warfarin. So it keeps us on our toes. But that's to avoid bias in the study. And this goes on for 6 months. And during the 6-month period, the number of new DVT or pulmonary embolism events is counted up. And the hypothesis in this study is that dabigatran would be non-inferior to warfarin, which it turned out to be. So there were 2,500 or so patients in the study, average age 55, about 40% female, mostly
as good as or even better than physicians managing your anticoagulation or an anticoagulation clinic managing it. You still be trained and supervised by us, and Renell is piloting that project in the clinic here at Brigham and Women's. Now, I've taught you a little bit how you can stay stable on warfarin. I've taught you what additional steps you can take. And I must say, if you're going to change anything because of this presentation, make sure you let your warfarin manager know. Because that initial change, you're going to require probably a dose adjustment. Then after that, you'll probably be more stable than before. So if you plan on changing anything, please call in and let us know. But other ways to stay safe on this medication, you can do everything perfect with your diet and alcohol and medications, but if you're not taking your doses, if you're missing doses, or if you're doubling up your dose, you don't have any real chance at stability. When you miss a dose, you can go from a perfect level, maybe a 2.5, all the way down to a 1.5, which is almost close to someone that's not taking warfarin, or below that. It's close to someone not taking warfarin at all. So it's very important to take all your doses. And if you do miss one, call into the clinic. If it's the next morning, skip your dose, call into the clinic. We'll help you make up for it. It's not perfect, but we'll help. And use a pill box. A pill box is a great tool for this medication, because if you put your medications in a pill box, if it's still there the next morning, you know you missed it. Or if it's not there, you know you took it and you don't double up on your medication. And we actually have a guide to taking warfarin at the desk over there. And in the back of it is a warfarin calendar where you can actually, it's made so you can record your doses of warfarin. You can slip that right under the pill box, so you record your dose. When your pill box is empty, you fill it back up with the recorded dose that you use in the calendar. It's a helpful tool, so if we don't have any more at the booth, then call into our clinic, we'll mail you one. And the other thing is, it's important to wear an identification card or a bracelet saying that you're on warfarin. I think that's extremely important. If you're ever unable to speak for yourself in an emergency situation, someone needs to know you're on this medication so that they can reverse it before they do any types of procedures in the emergency department. It's extremely important. And we have something you can mail in at the anticoagulation booths and get a bracelet. You can choose exactly how you want it. You can inscribe warfarin on the back. And we also have identification cards that you can just slip in your wallet, and someone will look there in an emergency situation. So with that, I'll open up the floor to any questions you guys have. Yes?
When you have vitamin K, like say I had a salad or broccoli, do you know how long it takes before it starts taking my blood, or how many days it stays in my system?
If you have, so the question is, how long does it take after you eat a green leafy vegetable meal, vitamin K meal, before you start to see a difference in your INR results? If you consistently change your diet for 2 or 3 days, or even 4 days, you'll start to see a change in your INR results within 24 hours if it's a big change, but mainly over about 3 days, you'll start to see a change in your INR. But you can see, if we gave you a big vitamin K tablet, we can start to see a result of that vitamin K within 12 hours.
How long does it last? Because Coumadin stays in my blood for 5 days with vitamin K. Is it out of my system the day after I eat it, or is it in there for a few days?
Your liver metabolizes the question again is how long does the vitamin K actually last in your system after you do eat a meal? And your liver actually breaks down vitamin K very quickly over 3 or 4 days. So that's why they use a daily vitamin K to kind of keep your levels nice and consistent. And that's something that you do that's supervised by us. It's not something you really start on your own. But over about 3 days, you'll really start to deplete your vitamin K stores after you fill them up with a green leafy vegetable meal. That's why it may not be enough to just eat one green leafy vegetable meal a week, because by the end of the week, that's depleted. Your levels went from high to low. Yes?
If one forgets to take it at night, can you take it the next morning and then get back on the same schedule?
If you forget your dose, the question is, what exactly do you do? If you forget your dose and it's still the same night, go ahead and take it. No. If you forget it, right. If it's the next morning, if you woke up and it's the next morning, then you need to skip your dose and give us a ring. Because you don't want to take warfarin the next morning, because then your next 2 doses will be about 12 hours apart and your levels can really spike. A lot of times, and it's sometimes the clinicians' own own way of doing it, but a lot of times what they'll do is they'll have you skip your dose and they'll make up for it with it by a little extra cumin the next night.
The U.S. Surgeon General issued a call to action to prevent DVT and PE, which emphasized public awareness about the risk factors, triggering events, and symptoms of DVT and PE. And then in April of 2009, the Joint Commission standardized hospital performance measures for the prevention of stroke and VTE. And most recently, NATF has been crucial in healthcare reform debates, particularly surrounding the testing of generic low molecular weight heparins and its effects on patient safety. So with that, I'll turn it over to Elle Howe, our Education and Outreach Coordinator, who will tell you a little bit more about NATF membership and our advocacy issues.
Thank you, Caroline. Hi, everyone. Once again, my name is Elle Howe, and I'm the Education and Outreach Coordinator for the North American Thrombosis Forum. My role at NATF is really to save lives and prevent blood clots through educating the general public, patients, as well as healthcare professionals on the recent developments on thrombosis research, education, public policy, and advocacy. I'm also here today to inform you of ways in which to get involved with NATF. So without further ado, I'm going to start about explaining our NATF website. Our website is www.natfonline.org. And here you can find information on all our past and upcoming events, which Caroline and Dr. Goldhaber have mentioned. You can also find thrombosis facts for patients, providers, and advocates. In fact, we recently added an interactive DVT-PE risk assessment tool in which it asks you a number of questions, and after answering those questions, it assesses your risk for developing a DVT or PE. I encourage you all to visit our website and try it out. We also have some contact information on our website. If you click on the link to the left, it'll give you two links at the bottom, and you can click on staff and office contact to contact either Caroline or myself. You can also find ways to get involved on our website. And lastly, you can register to be an NATF member. Hopefully after hearing from Caroline who we are and what we do as an organization, you'll be more apt to become an NATF member. So with that, I'm going to talk about the different perks to being an NATF member. As an NATF member, you have access to our online medical journal called the eThrombosis, which I will talk about further on in my presentation. You'll also receive a 25% member discount for all our educational events. Thirdly, you'll receive a membership card highlighting your username, password, and discount code to use when you register online to obtain that 25% discount. And lastly, you'll receive our monthly NATF newsletter, which highlights all our NATF activities within the past month. We currently have 4,337 members and counting. Something interesting about our members is that we have members in over 47 states. We have members in over 75 countries, and a breakdown of our membership as of December 2010 is that we have 37 pharmacists, 16% nurses, 17% other patients, 23% doctors, 3% students, and 4% PhDs. So as you can see, we encompass a wide variety of people. So now I'm going to talk about our online medical journal called eThrombosis, which I manage along with Dr. Sasahara, who's in the audience today. Our eThrombosis is basically an online medical journal for healthcare professionals affiliated with NATF to write about their recent studies or research regarding thrombosis. However, we also have a patient eThrombosis in which patients who've been recently diagnosed with DVT, PE, can share their personal story, convey a personal message to the general public, as well as share what you've learned since you've been diagnosed or treated with a DVT or PE. If you're interested in writing for the patient eThrombosis, I encourage you to please contact either Caroline or myself, and we'll be more than happy to get you started. For those of you who've been keeping up with the times, we have a variety of social media outlets. We have a Facebook, Twitter, LinkedIn, and YouTube account. For Facebook, simply search our organization's name, and you can ask questions on our wall participate in the discussion boards, view pictures from our previous events, as well as find information on our upcoming events. We also have a Twitter in which we tweet about recent news and updates regarding thrombosis and NATF. We have an NATF group in LinkedIn. And lastly, we have a YouTube account. Simply search for NA Thrombosis Forum, and you can immediately view all our educational videos, interviews, and patient advocacy videos. And lastly, we have a